Tuberculosis of spine. Introduction. Spinal tuberculosis, also known as Pott's disease, is the most common form of skeletal tuberculosis, accounting for approximately 50% of all bone and joint tuberculosis cases. It affects both males and females equally and can occur at any age, although it's more commonly seen in the first 3 decades of life. The development of the vertebral column starts in the embryo. Somites, which are paired cubical masses, begin to develop in the primitive mesenchyme by the 4th week of embryonic development. These somites differentiate into 3 components: dermatome, myotome, and sclerotome. The sclerotome surrounds the notochord. Each sclerotome undergoes segmentation and condenses into a cephalic mass, a caudal mass, forming the basis of vertebra formation. The blood supply to the vertebral column follows this embryonic pattern. Each segmental artery in the vertebral column supplies the caudal mass of the vertebra above and the cephalic mass of the subsequent vertebra below. This pattern is maintained throughout the fully developed vertebral column. However, the notochord disappears in the sclerotome region, except for the area of the intervertebral disc, where it remains as the nucleus pulposus. The nucleus pulposus, along with the annulus fibrosus, forms the intervertebral disc. The clinical importance of this embryonic blood supply is highlighted in the classical lesion of spinal tuberculosis. The tubercular infection involves the lower half of the upper vertebra and/or the upper half of the lower vertebra. This lesion is radiologically manifested by the narrowing of the intervertebral disc space, which is one of the earliest radiological signs of spinal tuberculosis. This finding confirms that the dissemination of the tubercular focus occurs through the bloodstream. Batson's plexus of veins. Batson's plexus of veins plays a significant role in the dissemination of infective focus from the genitourinary tract and abdomen to the vertebra. These veins connect the pelvic veins to the internal vertebral venous plexus and lack valves, allowing easy transmission of infections. Batson's plexus of veins. The connection between the pelvic veins and the internal vertebral venous plexus provides a direct pathway for the spread of infections to the vertebra. Cisterna chyli. The cisterna chyli, which is the origin of the thoracic duct, begins at the lower border of T12. Its proximity to the lower thoracic spine increases the likelihood of infection dissemination to this region. Close relation to the thoracic duct. The thoracic duct, responsible for lymphatic drainage, is closely related to the lower thoracic spine. This close anatomical proximity facilitates the spread of infection. Continuous movement with respiration. The lower thoracic spine experiences continuous movement with respiration, aiding in the dissemination of infectious agents. More spongy bone. The lower thoracic spine has a higher proportion of spongy bone compared to other spinal regions. This spongy bone provides a suitable environment for the growth and colonization of tuberculosis bacilli. Spinal tuberculosis lesions are most commonly found in the lower thoracic spine, followed by the upper thoracic, cervical, lumbar, and sacral spines. Several factors contribute to the high prevalence of lesions in the lower thoracic spine. Vertebral lesions. Vertebral lesions in spinal tuberculosis can manifest in different patterns. Paradiscal. This type of lesion primarily involves the adjacent vertebra, with intervertebral disc involvement occurring as a late feature. Radiologically, it's characterized by narrowing of the disc space. Central. In central vertebral lesions, the body of the vertebra is involved, often leading to the formation of a cavity. However, there is no collapse of the vertebral body on radiographic imaging, and a cystic lesion may be observed. Lateral. Lateral segments on the vertebral body are affected in lateral vertebral lesions, resulting in the lateral collapse of the vertebral body on radiological examination. Anterior. Anterior segments of the vertebral body are involved in anterior vertebral lesions, leading to anterior collapse of the vertebral body on radiographs. Posterior elements. In some cases, the posterior elements of the vertebra, such as the articular facets, may be affected. This can result in posterior spinal disease and spinal tumor syndrome. Lesions involving multiple vertebra and skipped lesions. Spinal tuberculosis can also present with involvement of multiple vertebra or skipped lesions, where some vertebra are affected while others remain unaffected. Clinical features. The clinical features of spinal tuberculosis, Pott's disease, can vary depending on the stage and extent of the disease. Common clinical manifestations include pain. Initially, the pain is dull and vague, but it gradually becomes more severe and constant. The pain is typically exacerbated by movement of the spine, especially jarring movements. Weight loss and decreased appetite. Patients with spinal tuberculosis often experience unintentional weight loss and a loss of appetite. Fever and malaise. Patients may have a low-grade fever, along with a general feeling of discomfort and fatigue. The temperature may show an evening rise, and night sweats can occur. Paraspinal spasm. Muscles surrounding the affected vertebra may go into spasm, resulting in paraspinal muscle tenderness and stiffness. Gibbous deformity. In advanced cases, the collapse of the affected vertebra can lead to the development of a gibbous deformity. This deformity can manifest as an angular, knuckle-like, or rounded kyphosis, giving the spine a hunched appearance. Tenderness over the spine. The affected area of the spine may be tender to touch. Cold abscess. A characteristic feature of spinal tuberculosis is the presence of a cold abscess. This refers to a soft tissue mass or swelling near the affected area, typically caused by the accumulation of pus. Cold abscesses are usually painless and may spontaneously rupture and drain. Aldermanic gait. Patients may adopt an aldermanic gait, which involves taking small, deliberate steps with a straight back in an attempt to minimize jarring of the spine and alleviate pain. Specific manifestations in cervical spine involvement. When the cervical spine is affected, patients may support their chin over the palm of their hand to relieve pressure and discomfort. Neurologic symptoms. In some cases, spinal tuberculosis can lead to compression of the spinal cord or nerve roots, resulting in neurologic symptoms. These may include weakness, sensory disturbances, numbness, or even paralysis, depending on the level and extent of the spinal movement. Types of kyphus, gibbous. When spinal tuberculosis, Pott's disease, leads to vertebral collapse, it can result in different types of kyphosis, gibbous deformities. These deformities are named based on the number of adjacent vertebrae involved. Knuckle kyphosis. This occurs when adjacent portions of two vertebrae are affected by tuberculosis, resulting in the collapse of the vertebral bodies in those segments. The resulting deformity resembles a knuckle with a sharp angular protrusion in the affected area. Angular kyphosis. When three consecutive vertebrae are involved, the collapse of these vertebrae leads to an angular kyphosis. The vertebral bodies collapse in such a way that the spine takes on a sharp angle resembling the shape of a triangle. Round kyphosis. In cases where more than three vertebrae are affected and collapse, a round kyphosis deformity can occur. This deformity is characterized by a more rounded hump or curvature in the affected area of the spine. Cold abscess. A cold abscess is a characteristic feature of tuberculosis and refers to a collection of fluid and debris resulting from the infection. It's called cold because it lacks the typical signs of acute inflammation such as warmth, redness, and pain. In spinal tuberculosis, cold abscesses can occur in various positions and follow different courses. In any region. Within the prevertebral fascia as a prevertebral abscess located in front of the vertebral body. Within the spinal canal, compressing the spinal cord. In the cervical region. Retropharyngeal abscess. This refers to the spread of a cervical prevertebral abscess behind the pharynx. Note, a pyogenic abscess in this region is situated in front of the prevertebral fascia and on one side of the midline, whereas a cervical cold abscess is typically located in the midline. The midline position can change if there's a rupture in the prevertebral fascia. In the mediastinum, cold abscesses can track down from the prevertebral region and assume a heart-shaped or fusiform appearance. In the back of the neck, cold abscesses can track along the posterior division of the spinal nerves. At the posterior border of the sternocleidomastoid muscle, cold abscesses can track laterally in this region. In the axilla, cold abscesses can pass through the open mouth of the axillary sheath. In the thoracic region, A. Prevertebral abscess in the posterior mediastinum. The cold abscess may remain in this region. B. Through openings in the diaphragm. Lateral lumbocostal arch. It can traverse between the lumbodorsal fascia and quadratus lumborum muscle, remaining behind the kidney. Medial lumbocostal arch. It represents the open mouth of the psoas sheath and can track down to the insertion of the psoas muscle into the thigh. Median arcuate ligament. The abscess can spread along the aorta and its branches. C. Along the intercostal nerves. Cold abscesses can be found in the anterior middle or posterior axillary lines within the chest wall. D. In the rectus sheath. Cold abscesses can develop over the anterior abdominal wall. In the lumbar region, along the major arteries and nerves, cold abscesses can track along the aorta and its branches, as well as the internal pudendal, superior gluteal, etc. They can follow the sheath of the psoas or quadratus lumborum muscles. They can travel along the lumbar, femoral, and obturator nerves into the thigh. Into the lumbar triangle of Petit. Cold abscesses can pass through the flat muscles of the abdominal wall in this region. Investigations. In the investigation of spinal tuberculosis, the following tests and imaging studies are commonly performed. Blood test. Hemoglobin, usually low due to chronic infection and associated anemia. Total count, moderate increase indicating an inflammatory response. Differential count, predominantly lymphocytes reflecting the immune response to tuberculosis. Erythrocyte sedimentation rate, elevated due to chronic inflammation. X-ray. X-rays of the spine are obtained to assess the extent of vertebral involvement. X-ray findings may include destruction of the vertebra, narrowing of the intervertebral space, anterior or lateral collapse of the vertebral body, cavity formation, and the presence of a soft tissue shadow suggestive of a cold abscess. Computed tomography and magnetic resonance imaging. Computed tomography and magnetic resonance imaging scans are used to provide detailed evaluation of bone and soft tissue involvement. These imaging modalities can help visualize the extent of vertebral destruction, the presence of abscesses or sinus tracts, and any spinal cord compression. Confirmatory test. Confirmatory tests for spinal tuberculosis may include acid-fast bacilli staining. Smears of the pus or tissue sample are stained to identify the presence of acid-fast bacilli, the characteristic bacteria of tuberculosis. This test can provide a preliminary indication of tuberculosis infection. Histopathological examination. Biopsy samples are examined under a microscope to look for classical tubercular granulomas, which are characteristic of tuberculosis. The presence of granulomas with caseating necrosis supports the diagnosis of tuberculosis. Polymerase chain reaction. Polymerase chain reaction testing can detect the DNA of Mycobacterium tuberculosis in the pus sample. It's a highly sensitive and specific test, providing rapid confirmation of tuberculosis infection. Tuberculosis of spine. Pott's paraplegia. Pott's paraplegia refers to the paralysis of the lower limbs that occurs as a result of tuberculosis involvement in the thoracic spinal cord. It's named after Sir Percival Pott, a British surgeon. Pott's paraplegia can also involve the bladder and bowel in severe and advanced cases. The sequential events leading to paraplegia and Pott's disease typically follow this progression. Muscle weakness. Initially, there may be weakness in the lower limbs. Awkward gait. The patient may have difficulty walking and exhibit an abnormal gait. Incoordination. Coordination of movements becomes impaired. Spasticity. Increased muscle tone and spasticity develop. Paraplegia in extension. Paralysis of the lower limbs occurs, typically in an extended, straight position. Paraplegia in flexion. Paralysis progresses to a flexed, bent position. Types of Pott's paraplegia have been proposed by Sorel, Dejerine, and Seddon. Early onset paraplegia. Paralysis occurs during the active phase of the disease, usually within 2 years. Late onset paraplegia. Paralysis occurs many years after the initial disease episode, often when the disease has become quiescent or even without reactivation. The causes of paraplegia in Pott's disease, as proposed by Seddon, can be classified into inflammatory and mechanical factors. Early onset paraplegia. Inflammatory causes. These include abscess formation, inflammation or caseating mass compressing the spinal cord, spinal tumor syndrome, and posterior spinal disease. Infective thrombosis of the cord can also lead to paralysis. Mechanical causes. Pathological dislocation of the spine, compression by sequestra, detached bone fragments, loose fragments of bone or disc, and pressure from granulation tissue and debris can mechanically interfere with the function of the spinal cord. Late onset paraplegia. Inflammatory causes. Paralysis may result from persistent disease activity or reactivation of the tuberculosis infection. Mechanical causes. Progressive stretching of the spinal cord over time can compromise its blood supply and function. Treatment. The treatment of spinal tuberculosis involves both medical and surgical approaches. The choice of treatment depends on the presence of neurological involvement and specific indications for surgery. Here are the details of the treatment options. Medical line of treatment. Anti-tubercular drug therapy. The cornerstone of treatment is the administration of anti-tubercular drugs. A combination of at least 3 or 4 drugs is used to effectively control the disease. Streptomycin may be used in certain cases. Close monitoring of liver enzymes and renal function is necessary, and modifications to the therapy may be required based on drug toxicity. Secondary infections, if present, should be treated with appropriate antibiotics. Nutritional support. Improving the patient's nutritional status is important, and attention should be given to a well-balanced diet. Immobilization. Immobilizing the spine using an appropriate brace or plaster jacket helps provide comfort to the patient and prevent the development of severe deformities. It also aids in the early consolidation of the affected bone. Surgical line of treatment. Surgery is indicated when there's paralysis or specific surgical indications are present. The indications for surgery are categorized as absolute indications, relative indications, and rare indications. Indications for surgery based on Griffiths and Seddon. Absolute indications. Paraplegia develops when the patient is on the adequate medical line of treatment. Paraplegia not improving with an adequate medical line of treatment. Paraplegia progressing even with adequate medical line of treatment. Complete paraplegia. Severe spastic paraplegia. Paraplegia of rapid onset. Long-standing paraplegia, more than 6 months, paraplegia in flexion, flaccid paraplegia, etc. Relative indications. Recurrent paraplegia, paraplegia in old age, painful paraplegia, paraplegia with complications such as urinary infection and stones. Rare indications. Posterior spinal disease, spinal tumor syndrome, cervical spinal tuberculosis, severe cauda equina paralysis. Surgical procedures. Drainage of abscess. If there is a large abscess that requires drainage, it's performed under the cover of anti-tubercular drugs and antibiotics. Smaller abscesses usually resolve with anti-tubercular drug therapy alone. Costotransversectomy. This procedure involves excising one or two ribs, transverse processes, and corresponding pedicles to drain a large paravertebral abscess. Anterolateral decompression. In cases where costotransversectomy does not yield pus under tension, anterolateral decompression is performed. It involves excising the posterolateral part of the vertebral body, ribs, transverse processes, and pedicles to clear tubercular debris and granulation tissue. Anterior decompression and fusion. This procedure is employed when the anterior portion of the vertebral body is destroyed. It involves decompressing the anterolateral portion of the spinal cord and followed by spinal fusion. Laminectomy. Laminectomy is performed in cases of posterior spinal disease and spinal tumor syndrome. Order of recovery of paralysis. Vibration and joint sensation. Recovery of vibratory and joint sensory perception is often the first sign of improvement. Temperature. Improvement in temperature sensation follows after vibration and joint sensation. Touch. Sensory perception to touch gradually returns as the condition improves. Pain. Recovery of pain sensation occurs later in the recovery process. Voluntary motor activity. As the spinal cord begins to heal, patients may regain voluntary control over their motor functions. Sphincter functions. Restoration of bladder and bowel control is a significant milestone in the recovery process. Wasting of muscles. The last stage of recovery involves a gradual reversal of muscle wasting and the restoration of muscle strength. Prognosis factors for spinal tuberculosis. Age. Younger age is associated with a better prognosis. General condition. Good overall health and physical condition contribute to a more favorable diagnosis. Duration of the disease. Shorter duration of the disease improves the chances of successful treatment and recovery. Severity of paralysis. Incomplete paralysis without bladder and bowel involvement is more likely to have a positive prognosis. Type of paralysis. Certain types of paralysis, such as spastic paraplegia, may have a better prognosis compared to complete or flaccid paralysis. Speed of onset. Slower onset of symptoms allows for prompt diagnosis and treatment, which can improve the prognosis. Degree of kyphotic deformity. Severe kyphotic deformity, particularly exceeding 60 degrees, is a negative prognostic factor and may affect the overall outcome of treatment. Images. Radiographs taken at monthly intervals at first, second, and third months of presentation, respectively. A. Narrowing of the joint space, which is the earliest classical sign of spinal tuberculosis. B and C. Progressive narrowing of the joint space as well as development of bony lesions. Healing occurs in the form of interbody fusion. A. Clinical picture, and B. Radiograph of a knuckle kyphosis. Note near total destruction of T11 and posterior subluxation. T10 is partially destroyed. Altogether, 2 vertebrae are involved, resulting in a knuckle kyphosis and the antero-posterior view. Note that the 11th rib is free of its attachment to the vertebral body, because the vertebral body is destroyed almost completely. Tuberculosis of the spine. Pott disease. MRI of 17-year-old fisherman showing tuberculous infection of adjacent thoracic vertebra with intervening disc destruction. That's all for the video. We'll see you next time.